So the thing is, trachea looks like this on cross section, and the esophagus is flattened, anteroposteriorly flattened, because it's a muscular structure. কোনো cartilaginous wall তো নেই, এটার trachea anterior wallটা cartilaginous. So it's always like this. Okay, and the vocal cords are like this. If you go to the larynx, the vocal cord is like this. If you come high up, vocal cord looks like this. So this coin, whatever is going, এখানে যেতে গেলে ওটাকে এরকম ভাবে ঢুকতে হবে, আর তো উপায় নেই, because it's flattened anteroposteriorly. Okay, আর যদি এয়ারওয়েতে ঢুকতে হয় তাহলে এরকম ভাবে তো ঢুকতে পারবে না, because it will get stuck in the vocal cords. So it have to come like this. So it should come like this. বেশিরভাগ লোক কিন্তু পরীক্ষার সময় ভুল বলেছিল। I am happy to see that এখন সবাই ঠিক বলছিস। ঠিক আছে, পরীক্ষার সময় তো this and vocal cord-টা মাথায় রাখবি। Just remember the vocal cords anteroposteriorly থাকে. It's a slit-like structure. So glottis is a slit-like structure. Anteroposteriorly it's a slit-like structure. So the foreign body has to go like this. It cannot go like this. If it's going like this, if it is going like this, it will be, when we are seeing it from the lateral side, we can see the entire thing. But from anteroposteriorly, it's just a slit. Okay, so clear about this one? Any questions? So how will you say? So we'll say that it's a skyagram of the thorax or the chest showing a foreign body in the trachea. আর একটা এক্স-রে আমি দেখাচ্ছি, এটা দূর থেকেই দেখ, should be fine. Another good X-ray. See this one. What is the difference between the previous coin X-ray and this one? Whatever. Foreign body to dutoi. Exactly. So that is the difference. This is a foreign body in the bronchus. Why are you saying it? Because when we are seeing the AP X-ray, it's lateral. It's going lateral. So the trachea is like this after the carina. ওটা carina হতে পারে, carina উপরে হতে পারে, anywhere. Okay, but this has gone into the bronchus. That's why it is like this. Because esophagus এরকম ভাবে ঘুরে যায় না. A trachea is a straight structure. So it has to be the bronchus. Unless it has perforated and gone into the mediastinum. Esophageal foreign body going to the mediastinum after perforation, that's a rare entity. And we do not do X-rays for that, we do CT scans. Because the patient will come with severe chest pain, toxic patient, lot of things. So we'll go for a CT scan, we won't wait for an X-ray. Okay, but foreign body in the esophagus, perforating the esophagus, going to the mediastinum can look like anything. Because it can be anywhere in the mediastinum. Try এটা একটা বারবার বলছি, your examiners will be all from the center. I mean external examiners. আর X-ray এগুলো কিন্তু externalরা বেশি নিতে প্রেফার করে। The short tables, because they know where to stop you. Long case, everyone will get, if it is say 20 marks, most of you will get around 10 to 12, 13 max. যারা খুব ভালো will get 15 honors marks. Those are very good. But these small tables, they make the difference. I'll repeat. So don't make mistakes here. See, if you secure all the small tables, even if your long case is not as good, অতটা ভালো হয়নি, then also you'll pass. যেমন ধর তোদের থিওরিতে there are a lot of small questions, right? There were one word, this matching questions and all those MCQ type of questions. If we get all those correct, maybe 10 or 12 marks was there. If we get all those correct, তো 10 marks ওখানে উঠে যাচ্ছে। So বাকি 40 এর মধ্যে তোকে 15 তুলতে হবে। So 15 out of 40 is way easier than 25 out of 50. So make sure you answer the smaller tables and the smaller questions correctly. See, long questions you have to, obviously long cases তোকে পড়তে হবে, but those are long cases are usually with the theory. Chronic tonsillitis, say chronic otitis, তোর থিওরিতে এমনিই পড়বি, কিন্তু আলাদা করে কেস ওয়াইজ ওগুলো নিয়ে খুব স্ট্রেস নেওয়ার দরকার নেই। But these short cases, spot diagnosis, this X-rays, reasoning questions, এগুলো if you can secure near full marks, then your pass is definitely secure, and it's easier to get honors as well. এদিকে দেখেছিস তোরা? অতক্ষণ ধরে দেখলে হবে না, তাড়াতাড়ি তাড়াতাড়ি। বোঝাচ্ছি, বলবো, দেখিয়ে বলবো, দেখিয়ে দেখে নে একবার, চোখে দেখে নে, তারপর আমি বুঝিয়ে বলবো। আমি কি না দেখে পালিয়ে যাবো? ছবি তুলবি না কেউ, বারবার বলেছি, ডোন্ট টেক ফটোগ্রাফস, কারণ এই এক্সরে গুলো এমনিও থাকবে না, ইটস নট ওয়ার্থ। আর ফটোগ্রাফস ওরা বইয়েই পেয়ে যাবে, সব বইয়ে ছবি আছে, নাথিং নিউ। এটা রোটেট কর, রোটেট দিস ওয়ান অলসো। আরেকটু পরে এলে হবে, আরেকটু পরে এলে সুবিধা হতো। আরেকটু খুঁজে, তো কলেজ তুই খুঁজে পাচ্ছিস না? বাহ, তো বিশাল স্টুডি আসবে। হ্যাঁ, কেন? CR was informed. If you are not informed, there is a fault of the CR, not mine. CR কে আগে ইনফর্ম করা হয়েছে। CR ফার্স্ট বেঞ্চে বসে সবার আগে চলে এসেছে, সবার আগে চলে এসেছে, কিন্তু CR ফার্স্ট বেঞ্চে বসেছিল, আমি ঢুকতে দেখেছি। If he is not informing you, he is at fault. দে 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 দে। আরে একটা দে, তিনটেই নিয়ে বসে আছে, তিন সব দিকে। না, ওটা না দেখালে বুঝতে পারবে না, ডিফারেন্স গুলো বোঝা পাচ্ছিস, তিনটে এক্সট্রার মধ্যে ডিফারেন্স আছে। See, you are not understanding, tell me, I'll explain in English, no issues. We are supposed to take this class in English only. It's just that everyone is familiar with Bengali and people can ask questions freely, that's why I go for Bengali. It's not a problem at all. You tell me what you don't understand, I'll explain in English, no issues. দে বাবা দে, অনেকক্ষণ হয়েছে, ফটাফট ফটাফট দেখ, তাড়াতাড়ি। কতক্ষণ লাগে একটা ছবি দেখতে? So first this one, where are the other ones? See, these two, এই যে দুটো এক্সরে দেখালাম, what is this? Who will tell me? It's X-ray of showing lateral view of neck, lateral view of X-ray soft tissue of neck, lateral view showing why do you think this is an abscess? What is the signs of abscess? It's a foreign body in the esophagus. Okay, we can see some radiopaque foreign body in the esophagus. It can be a fishbone, a mutton chip, you do not know. Unless you take it out, you do not know. Just say it's a foreign body, radiopaque foreign body. About that, try to understand the difference. That's why I gave these things to you. See here, the trachea we can see anteriorly, esophagus is posteriorly. See the bulge this one is having, and the bulge this one is having is different. This bulge is way more. Okay, and if you go to the third X-ray, see the bulge. This one is clearly showing air fluid levels. That means there has to be an abscess. That can be a complication of a foreign body, That can be complication of an otherwise infection, maybe a tubercular abscess, whatever be it. It's a retro-pharyngeal abscess. So this one where you can see air fluid levels or air pockets, this has to be an abscess, nothing else. Okay, and I don't appreciate any genuine foreign body over here. There's some ossification of the cricoid cartilage. Apart from that, there's no definite foreign body visible. Okay, but in the other two, you may not appreciate the abscess as much. There is inflammation, but you can appreciate the foreign body in there. Okay, see the differences between these two. Okay, so how the esophagus is? So clear about this one. So this is a skiagram of the soft tissue neck lateral view showing foreign body in the esophagus or showing a retropharyngeal abscess. Then the examiner will ask you which age is this common, what are the causes of the retropharyngeal abscess. So you start with foreign body, go to infections, chronic infections, and gradually go on. Start with foreign body because that is one of the commonest cause. And the commonest cause in our country is tuberculosis. Okay, so your answer should have at least these two. Apart from that, there can be multiple other causes. Any trauma, any post-surgical, there can be so many things. Any other infection can also be there. So, but these two you should not miss. Retropharyngeal abscess, tuberculosis, and foreign body esophagus you should not miss. Okay? Huh? Foreign body, tuberculosis. So any chronic granulomatous infection can give rise to a retropharyngeal abscess. But it's a cold abscess, it behaves differently. So there's a long-standing low-grade. So the examiner, if I was asked in my MS exam, though, that how will you differentiate? It was a CT scan, not an X-ray, but he asked me how will you differentiate between foreign body induced retropharyngeal abscess and a tubercular retropharyngeal abscess. So thing is, in a tubercular infection, the history will be completely different first of all, but sometimes patients may not appreciate ingestion of any foreign body. Khete khete mukhe dhuke geche. We sometimes don't even notice. While eating, we sometimes take fish bones. It goes in, or maybe small chips of mutton or chicken that goes in. We don't even sometimes appreciate. But later on, we start having pain in the throat, and if we are having a retropharyngeal abscess, we start having pain in the throat, and the other symptoms will set in. In a tuberculosis patient, you will have a history of chronic fever. A retropharyngeal abscess caused by a foreign body for in 2-3 days or maybe 5 days will not have a chronic fever. There will not be any weight loss. Tuberculosis may have weight loss. So all other symptoms will suggest me, the history of the patient will suggest me there is a chronic infection or this is an acute issue. If an acute issue, it's most likely a foreign body that has caused it. Or if there is a history of any surgery immediately, so that is a common cause. Okay, so try to think and answer. So now this one I think everyone knows. Sabai Janish? Who's the bachis? Can understand this one? I'll show. Kaç থেকে দেখ একটু. Any particular thing you can appreciate? Who on earth does a lateral view for sinuses? The examiner will throw you out of the examination room. Never say. The only reason we do a lateral X-ray of the nose or sinuses is to see a nasal bone. Okay. Sinus, we never take a lateral view. Remember it. ठीक है. This is a fractured nasal bone. Okay. Now see closely. I'll explain the things. Okay. So this patient will present to you with a trauma, history of trauma. Obviously, it's a fracture, so history of trauma, pain, swelling. The examiner will ask you, what will you do? নেজাল বোন আর সেপ্টাম এক হলো, তাহলে কি করে সেপ্টোপ্লাস্টি করে দিবি? What is septoplasty? What is septoplasty? Repair of nasal septum is septoplasty. Since I wanted this answer so that I know where the problem is. See, septoplasty is an elective surgical procedure to correct a deviated nasal septum. It has nothing to do with a fractured nasal bone. Okay? It's an elective surgical procedure. Septoplasty is an elective surgical procedure. It's not an emergency septoplasty. But correction of the nasal bone is an emergency procedure. There is a fracture. So, what we assess is dislocation. If the nasal bone is comminuted and dislocated, then we need to intervene and we need to reposition it and correct it. Many a times we see the X-ray and say it's fractured or it's not dislocated. You don't need to do anything. So see, the nasal bone is like this, say. It looks like this on the X-ray, no? So there is a fracture and this bone has gone like this. So the patient will have a swelling over here, edema, pain and all those things. So what we do is, we reduce this to this. Nasal bone from the front, it actually looks like this, na? Right? So this part is the one that is jutting out. So the fracture is most commonly comminuted. There are multiple fragments. So what we do is, we use, so there will be two instruments, Asher's forceps, Walsham's forceps. You have seen in the instrument table, we will show it. I don't think we have it, maybe in the OR, I'll show you. Or I'll bring mine and show you before the exam. Okay. So we reduce the fracture segments, put it in place, and then we do a splint. We put a splint over it. Okay, so that those stay in position. That's the reason. Okay. So fracture nasal bone, if the examiner asks you what to do, so splint. Nasal splint I have not seen. এরকম একটা প্লাস্টার কাস্টের মতো হয়। No. Temporary splint. So it's something that you put from outside, like a plaster cast. হাত ভেঙে গেলে যেরকম কাস্ট লাগানো হয়, it's like that only. Okay, but it's made in the shape of the nose. You can just put it in there, or you can use a cast also. Government hospitals, when we used to do, we never used to get a splint. Those are costly things. That's the ideal thing, but they are costly things. We'll take a small plaster cast, POP, and put it, plaster of Paris, and make a splint for the patient. That's how we do it. Okay. So, and what about septoplasty? Septoplasty is for correction of a deviated septum. Okay. So there are two parts, two terms you have to understand. One is a septoplasty, one is a rhinoplasty. What is the difference? What do you mean by nose? DNS is a nose deformity. What is that called? So the external framework of the nose. Rhinoplasty is correction of the external framework of the nose, either to give a cosmetic outcome or a functional outcome. ঠিক আছে? And septoplasty is correction of the septum, the nasal septum, not to the external framework. Sometimes we do both the procedures together. We call it a septorhinoplasty. বুঝতে পেরেছিস? So septoplasty is for septum, rhinoplasty is for external framework. Completely different surgeries, completely different thinking. ওই ফ্র্যাকচারের এক্সরেটা কোথায়? চলে গেল, ওটা গেল। ওটা বাড়ি নিয়ে চলে যাবি নাকি? দে রে, কটা একটাই তো নাক আছে, কতবার দেখবি ওটা? মানে এক্সরেতে একটা নাকে নিয়ে সবাই মিলে 10 বার করে দেখবি। পরীক্ষা লাগে সব আবার দেখাবো, চিন্তা নেই বাবা, ইম্পর্টেন্ট গুলো দেখে না। বুঝতে পারবি তোরা? দেখ, now first tell me, দূর থেকে আগে দেখে বল, if you are given this X-ray, what would you say?
It is the base of the skull.
What are you saying, Ayush, today? What happened to you? Oh, you are talking nonsense today. Think about it. Where is the base of the skull? X-ray of skull. See the difference between these two. Okay, let's take this. It's easier for you. What would you say? This is X-ray of skull. Key view? Occipitomental view. Waters view. So it is like from the occiput to the mentum. So the occiput and the mentum are in the straight line. It's like this. So that's why it's called an OM view or occipitomental view. OM view bola hai. Okay? So why we do a OM view? কি করার জন্য কি দেখার জন্য করি আমরা? Mainly for paranasal sinuses. Mainly for evaluation of the paranasal sinuses. দিয়ে দেবো আমি বকা খাবো স্যারের থেকে। So the development of sinuses you will have to read. This is important because the examiner will ask you, many a times it is asked, from the X-ray, what do you think will be the age? So whether frontal sinus is developed or not, pneumatized or not, how the maxillary sinus is pneumatized, all these things. And this will need a special separate class, at least half an hour, 40 minutes for this, for the development of the sinuses. Whenever you want to have that class, let me know. We'll sit together in the OPD or here, wherever, and we can discuss, because it's a theoretical class. Okay, but you need to know what all things you need to see in the X-ray or even while giving the exam. And what is this? There is nothing called occipitofrontal view. It's a কে বলতে পারবে? আচ্ছা, very close AP view. Okay, this particular name for this view, have you gone through this? পড়েছিস কেউ? So why do we do this? Why do we do this? To see what? Huh? Actually, yeah, she is right. Sinus দেখার জন্য I'll do an OM view. Why will I do this one? OM view তো বললাম, OM view sinus, এটা মাথায় রাখবি। OM view দেখ, হ্যাঁ? Little cilia is a mucosal structure. Is it a bony thing? What is little cilia? It's junction of the arteries. Is it a bony place? না তো little cilia তুই কি করে appreciate করবি? It's not a bony structure. Little cilia is a vascular space. It's a soft tissue. তাই না? Anterior inferior part of the septum. It's a cartilage, soft tissue. There is no bone involved, so you cannot see it on X-ray. Don't comment on something that you cannot see on X-ray. Okay. So there is a reverse Townes view to see the styloid processes. So these are the base. This is the base of the skull from which the styloid processes have emerged. চারবার কোথায় থাকে? styloid process ইয়ারে থাকে। styloid process কোথায় থাকে? হ্যাঁ, তো এখানে কোথায়? এটা বল, কোথায় থাকে? নিচে, এই যে এক্সামিনার করে স্যার এইখানে থাকে স্যার। কিসের এক্সরে স্যার? এইটার এক্সরে স্যার, না কানটা নাম মনে হচ্ছে। ম্যাস্টয়েডের নিচে styloid process থাকে। Then what is stylomastoid foramen? First year pass করে এসেছিস, বলা উচিত। What are the structures coming out of stylomastoid foramen? Only ছড়াস না হ্যাঁ না ক্যাটবেল না সে stylomastoid foramen দিয়ে jugular vein বেরোয় হ্যাঁ there is nerve and a few small vessels. And what are the branches of the facial nerve in the stylomastoid foramen? তো যা মনে আসছে বলেছিস, আমি কিছু ভালো মোডে আছি বলে যা ইচ্ছে বলছিস। হ্যাঁ বললাম তো রিভার্স Townes view. to see the styloid processes. Mainly styloid process দেখার জন্য, because there is a syndrome called Eagle syndrome or stylalgia. The patient will come to you with chronic pain, mostly in the one side of the throat, or may have bilateral pain, mostly when he or she is swallowing, having difficulty, that is dysphagia, having difficulty in swallowing of food, and it's a chronic problem for quite some time. Okay, so you have seen that there is no tonsillitis, no reflux disease, everything excluded. You cannot find out the cause. Many a times this happens. Okay, we go through all the ultrasonography if the neck is normal. We do a fiber optic laryngoscopy to visualize the larynx, it is normal, but still the patient is having continuous difficulty, and typically the patient says the pain comes from here and is referred down. And then we suspect something like a stylalgia, a pain from the styloid process. Why? Because there may be stiffening of the muscles attached to the styloid process. It's called Eagle syndrome or stylalgia. Okay, so the treatment is so not this one. The treatment is to remove the styloid processes. Okay, so there are two types of approaches. So styloid process lies in the tonsillar bed. We go from the mouth. Okay, so we do an intraoral approach. We remove the tonsil. So if you go through the anatomy of the tonsillar bed, you have heard of styloid process in there, right? Carotid styloid process. পড়েছিস তো? মনে করে দেখ, recently you studied for the exam. Tonsil bed comes in relation to the styloid process. So we do an ipsilateral tonsillectomy. We separate the fibers of the constrictor muscles and we reach the styloid process. We dissect the styloid process from all its muscular attachments and remove it. So the tension in the muscle is gone. Okay, and the patient's pain is relieved. So what is this X-ray? X-ray te bolbi na sir adenoid. Ki bollam? This is diagram of what? Lateral view of nasopharynx. Soft tissue X-ray of the lateral view of nasopharynx, or X-ray of the soft tissue nasopharynx lateral view, to visualize the adenoids. Okay, then the examiner will ask you, okay, that's good. So what are the symptoms? What can be the symptoms in this patient? Nasal obstruction. So adenoids usually occur in kids. The kids won't come to you and say that I am having nasal obstruction. Pain fever. So, when do we have pain fever? There is an infection. So do you think there is an infection? হেডেক, দেখ এরকম কোনো রোগ নেই যাতে হেডেক হয় না। তোর এখনো হচ্ছে, আমার হচ্ছে, সবার হচ্ছে। So headache is something is very overgeneralized. Don't say. Headache is one of the last answers. যখন কিচ্ছু বলতে পারছিস না, দেখবি আর কিছু পাচ্ছি না, লোকে ডোমপেডনের সাইড এফেক্ট অফ ভমিটিং বলে। I have seen people say that. So that is not an answer. Don't say that. Dysphagia. Why would the patient have dysphagia? It's high up in the nasopharynx. Adenoid is in the nasopharynx, right? Patient will come to you and tell you, sir, I'm having otitis media with effusion. Can you check my adenoids, please? No, this is not US. Huh? Difficulty in breathing. Okay. So usually the patient is a kid, right? The patient won't complain of difficulty in breathing, but the mom will say, the patient snores. It's constantly mouth breathing. Whenever he or she sleeps, keeps his mouth open. Okay. So snoring, breathing, habitual mouth breathing. Habitual mouth breathing. Okay, these are two commonest symptoms of adenoids. What are the other things? Like someone said, otitis media with effusion. Yeah, the patient can have otitis media with effusion and can have multiple episodes of acute otitis media. Recurrent acute otitis media in presence of enlarged adenoids is an indication of adenoidectomy. One of the most important indications of adenoidectomy. তাহলে কি হবে symptom ভাব? There is some soft tissue in the nasopharynx, so it's blocking the choana. নাক থেকে হাওয়া যাচ্ছে না, the air is not going from the nose to the along its normal passage, so the adenoid is obstructing the airway. So what will happen? The sinuses won't be able to drain properly because the airflow is restricted. The patient will have sinusitis, continuous nasal discharge, because the discharge that normally comes off the sinuses goes through the nasopharynx into the throat. We don't even feel it. It's always going on. But here, the adenoid is obstructing the choana, so the discharge cannot go in. The patient will have continuous nasal discharge. So nasal discharge, mouth breathing, snoring. Don't forget these three symptoms. মনে থাকবে তো এবার, বুঝতে পেরেছিস? Adenoid is obstructing choana, discharge পেছনে যাচ্ছে না, কোথা দিয়ে যাবে? সামনে দিয়ে বেরোবে, নাক দিয়ে discharge আসছে, নাকের পেছন দিকটা বন্ধ, patient cannot breathe, so he will breathe through mouth. আর ঘুমোবার সময়, so we humans are nasal breathers primarily, so we always try to breathe through nose first. Snoring will be there because you are forcing air through a small passage that is left behind. No doubts about these symptoms, right? So the examiner will ask you, when do you think you need to operate this patient? When and why will you operate? আমরা কখন adenoid operate করি? Recurrent otitis media. So the patient is having symptoms of obstruction so as to compromise his or her daily life. There is failure to thrive in children. The patient cannot have a good sleep, so growth is hampered. Patient is having recurrent otitis media with effusion, hearing less, or not following the class. Many a times, so you see, in Western world, so due to work, I was in US for 3 years, so I have seen many kids, their parents will come and say that, doc, this kid is just annoying me. They'll say like this, it's just annoying me, won't listen to anything in the class, will come back, the teachers are calling every day, I don't know what to do something, and they'll shout like this. And typically 90% of them will have adenoids. Okay, so complaints of adenoids are not from the kid, it's from the guardians or the parents. Remember that, and then everything will fall in place. Okay. Failure to thrive means the patient is not being able to sleep properly. Okay, so its daytime sleepiness will be there. Patient will sleep during the daytime. A kid who is supposed to run and have fun, enjoy his life, play around, will not be doing that. Will always be tired because he's not sleeping well at night. Okay, so all these together will tell you whether to go ahead with the surgery of the adenoids or not. So what is the conservative treatment if you're not going in for a surgery? What are the medications? Decongestion is something that's temporary, it can help, but it's temporary. You cannot go on decongesting the nose for a long time. Steroids, so intranasal corticosteroid sprays. It has been shown to reduce the adenoid hypertrophy over a long time. Okay, when we are using it for months, have shown significant results in. মুখস্থ করে বললে হবে না, I want it in the exam format. পরীক্ষায় কিভাবে বলবি? Tell me. This is a barium swallow X-ray of the esophagus showing Achalasia Cardia. লেখা আছে Achalasia Cardia এখানে। But a sudden narrowing of the esophagus or a bird beak appearance. In the distal esophagus, very good. In the acute narrowing of the distal esophagus. Okay. Most likely this is a case of an Achalasia Cardia. You cannot diagnose like that. See, Achalasia Cardia, for diagnosis you need to do a pressure monitoring. You need to do a pH monitoring. You don't have those. Just with an X-ray we are not Vidhan Rice. No, we cannot say like that. Okay. So explain the X-ray in details, whether it's an AP view or a lateral view or whatever, and then say what is your finding in the X-ray, and then say the most probable diagnosis. Go step by step. Okay, don't rush to the diagnosis first. There's a wrong way of explaining an X-ray. বল কে বললি এটা? বল তুই আমাকে বল, I'll correct you. কাল আগে তো অ্যাডিনয়েডটা চেক করা। So this is a barium swallow X-ray of the esophagus, showing a acute narrowing of the esophagus, lower esophagus. Okay, বুঝতে পেরেছিস? Acute narrowing of the esophagus দেখতে পেয়েছিস? Or a barred beak appearance. Most likely the diagnosis, this is a case of an Achalasia Cardia. Then the examiner will ask you, what are the other diseases where you can find narrowing? যেখানে তুই এক্সরে করলে এরকম narrowing পাবি। Very good. Strictures. Don't say atresia, strictures. Because atresia is a congenital. Don't go with atresia, stay strictures. I understand what you mean to say, so stay strictures, okay? So there can be strictures, there can be malignancies, but malignancies will have an irregular filling defect. So there is a difference. This is coming and stopping like this. A malignancy will be like this. Somewhere it will be more, somewhere it will be less. So it's an irregular filling defect. Okay? Because there is a mass in the esophagus. So mass এর পাশ দিয়ে bariumটা যেরকম ভাবে গেছে, you will get that picture. But এখানে তো there is no mass. There is just sudden narrowing.